Hello, and welcome to A Sound Constitution here on CHLY 101.7 FM, a show where we focus on health topics important to our community. This year's team is made up of 8 third-year VIU nursing students. Our goal is to demystify health issues and address common misconceptions by sharing evidence-informed information from a variety of reliable resources. All information provided on our show will be available in our show notes on our Facebook and Instagram pages. We want to remind our listeners that the information presented in this show is for educational purposes only and does not replace the advice of your primary healthcare professional. If you have any questions or concerns about what's being discussed, please feel free to reach out to us on Facebook at A Sound Constitution, Instagram at CHLY A Sound Constitution, all one word, Twitter at ASC_VIU, or email us at asoundconstitution@gmail.com. We would like to start our show by acknowledging that we are on the unceded territory of the Sunemu people, with a broadcasting range that overlaps the Kawatsan and Sliamon territories. This acknowledgement is done with gratitude to the Sunemu people and with the intention to increase awareness about truth and reconciliation processes and efforts here on Vancouver Island. Additional information and resources surrounding Sunemu history, reconciliation, protocol, and land acknowledgement can be found on our Facebook, Instagram, and YouTube pages.
Hi everyone, thanks for tuning in this week. I'm Stella, your host for this episode, and I'm here with my co-hosts Shan, Cedric, and Lara. Today we will be talking about demystifying MAID misconceptions. And later on, we even get the pleasure of interviewing Dr. Caroline Varieth, a professor here at Vancouver Island University. There are many myths out there about MAID, so we will be working to demystify them by going through what MAID is, some statistics about it, and answering some questions you may have. We also will be hearing about some real stories from people and their families who have chosen MAID. In this episode, we will be talking about death, so if that topic is triggering, then this episode may not be for you. But make sure to tune in next week. Saying that, let's get right into things and talk about what MAID really is. So, what is MAID? Well, it stands for Medical Assistance in Dying, and according to the Government of Canada's website, it is a process that allows people eligible to receive assistance by a medical professional in dying, which in simpler terms means giving the choice to those eligible on how they would like to die, whether that is naturally or through medical assistance in the form of a pill or injection. Now, in that definition, it mentions that this is only available to eligible people. So, what are the criteria that make someone eligible? In order to be eligible, you must meet all of the following criteria. 1. Be eligible for health services funded by a province or territory or the federal government. 2. Be at least 18 years old and mentally competent, which means being capable of making health care decisions for yourself. 3. Having a grievous and irremediable medical condition. 4. Make a voluntary request for MAID, so it cannot be the result of outside pressure. 5. Give informed consent to receive MAID. Now, there are some terms in there that can get misinterpreted sometimes, so we're going to go a little deeper into those specific terms. First, what counts as a grievous and irremediable medical condition? Well, there's 3 criteria that are listed for this. 1. Having a serious illness, disease, or disability. 2. Being in an advanced state of decline that cannot be reversed. And 3. Is experience unbearable physical or mental suffering from your illness, disease, disability, or state of decline that cannot be relieved under conditions that you consider acceptable. However, as of right now, having solely a mental illness does not count under the criteria for MAID. Now, the last criteria for MAID was giving informed consent, which means you give permission after you have all the information about your medical diagnosis, available forms of treatment, and available options to relieve suffering, including palliative care. After getting all that information, You have to give consent at the time of the request and right before receiving MAID. And this consent can be taken away at any time, stopping the whole process, whether that's right before receiving or long before. Now, if you meet all these criteria, there are still multiple safeguards to ensure only people who are eligible and giving full informed consent are the ones to receive MAID. These safeguards include having 2 independent medical assessments to determine if someone meets all the criteria, make a written request signed by independent witness, and an independent witness means that the witness cannot gain anything from the death, cannot be an unpaid caregiver, or an owner of the medical institute they are currently receiving treatment or living at. You must also know that you can withdraw your request at any time, and you have to provide final consent. Advance consent can be given if applicable to your case. Everything I just said can be found on the Government of Canada's website. Now that we have given you some background about what MAID is and who is eligible, it shows that this is not an easy process to go through, and there are many steps to ensure people are getting MAID because they are eligible and for the right reasons. Now that we've gone over what MAID is and who qualifies for it, Shanna's going to talk about the statistics of MAID all over the world and here right in Canada.
Medical assistance in dying has been a topic of debate and legislation in various countries around the world. According to Dying with Dignity, a national human rights charity in Canada, in 2022, a small number of countries have been expanding access to different forms of MAID. Countries such as Canada, Belgium, Switzerland, the Netherlands, Luxembourg, New Zealand, Colombia, Spain, as well as some states in Australia, USA, and DC have legalized MAID. However, the eligibility criteria, safeguards, provision, and scope of access vary significantly from one jurisdiction to another. The legalization of MAID has taken different forms in the said countries. Some have passed legislation to allow for MAID, while others have legalized it through court decisions. This diversity in approaches reflects a complex ethical, legal, and societal considerations surrounding end-of-life care and individual autonomy. Meanwhile, medical assistance in dying has been legal in Canada since 2016, and in this segment, I will be talking about the prevalence of this end-of-life option in Canada. The most recent statistics on MAID were reported in Canada's 4th annual report in the year 2022, and according to the report, there were 13,241 MAID provisions reported in Canada, bringing the total number of medically assisted deaths in the country to 44,958 since 2016. This represents a 31.2% increase compared to the numbers from 2021, and medically assisted deaths accounted for 4.1% of all deaths in Canada in the year 2022. Additionally, it was noted that a slightly larger proportion of males than females received MAID, with males accounting for 51.4% and females for 48.6% of the total. The primary setting for the administration of MAID was private residences with 39.5%, followed by hospitals with 30.5%, palliative care facilities with 20.8%, residential facilities with 7.6%, and others such as ambulatory settings or medical offices or clinics with 1.5%.
Hello, it's time to take a break and talk about Frances' story. Frances' mother decided to choose MAID in 2019 after having ongoing health issues due to treatments she was on for her leukemia, which is a type of cancer. Her mom had been living with leukemia for about 25 years, and one of the drugs she was taking had a side effect of creating foot ulcers after prolonged usage. Her mom was not satisfied with her quality of life as she was in constant and excruciating pain. After suffering a stroke on top of all the other health problems that she already had, her mom said to her daughter, "I am done, I am so done," which prompted her daughter to talk to a physician about MAID. Her mom decided to go forward with MAID after being informed of the process, and a doctor came and assessed her mom to make sure she met the criteria. When Frances' mom was told that she could go forward with MAID, she was happy to finally be in control of her life. The procedure was scheduled, and Frances' mom got to spend her last days with family instead of being constrained to a hospital bed. The whole family was present the day that Frances' mom received MAID, and her daughter describes the whole process as being very positive and peaceful for her mother. Frances says that dying with dignity is what we should be aiming for in end-of-life care, and MAID can help provide this. Frances says that her mother's death was easier for her as the whole family got to say goodbye, and her mother was in her own home when she died, surrounded by people she cared for. This story comes from the website Dying with Dignity, which will be referenced in our show notes.
You're listening to the Sound Constitution here on CHLY 101.7 FM, where we work to demystify health topics, and today's episode is on MAID. We will be talking about death in this episode, so if that is a triggering topic, then this may not be the episode for you. But make sure to tune in next week. Now, let's get back to the episode. Next up, Lara will be interviewing Dr. Caroline Variath, who received her BSN from Rajiv Gandhi University in Karnataka, India, a Master's of Science in Nursing from Charles Sturt University in New South Wales, Australia, and a PhD in Nursing Science with a collaborative specialization in bioethics from the University of Toronto. She's been practicing for 15 years with acute and critical care experience and was even on a MAID team in Ontario. We will be interviewing her on her findings on MAID and what she thinks about some common misconceptions.
All right. So first of all, I just want to welcome you, Caroline, and really appreciate your time today. And thank you for coming to talk to us and share with our community a bit more about MAID and what it means. So first of all, I just wanted to ask you what inspired you to study nursing and more specifically ethics, bioethics.
Yeah. Just before we begin, I would just like to make a statement that everything that I share here is my own opinions. It's not really the opinions of any of the organizations that I represent or that I'm affiliated to. And so talking about my sort of introduction to nursing, I really don't know when that began. It's sort of organically developed, and I always knew that nursing was something that I wanted to do, but I don't really have a point in time or something that I can point to and say, that's what, led me to decide to join nursing. And then my interest in ethics or healthcare related ethics sort of developed within my nursing practice. So once I graduated and I was working in the clinical setting, a lot of things that I experienced while providing care to patients were ethically distressing or morally distressing because of how things unfolded within the healthcare system. And I knew that there could be a better way. And so that sort of intrigued me, interested me. And so I've pursued further education and work with the ethics team of the organization that I worked for, but also in my education that followed.
Very good. Amazing. Thank you for sharing all of that. And I'm curious, what kind of influenced you and led you to work in the field of MAID and to study this area of research in healthcare?
Yeah. So my clinical background was mostly acute critical care. And so I worked for many years in critical care intensive care units. And while working there, I was witness to, obviously, I was involved in saving a lot of lives, and it is an important area of healthcare that, that can be useful for people who are experiencing severe illnesses and to sort of recover from that. We are very well equipped to do that. But I also saw very many people, especially elderly patients who died in the critical care settings, and often I was the only one in the room with that patient. And so that was, again, one of those ethically and morally challenging experiences for me, because I really did know that death could occur in a better way. These people, had they had they had the information about the different options that were available to them, then maybe they wouldn't have chosen to die in a critical care setting. That might be also information about their own the trajectory of their own illness and trajectory of their or prognosis of their illness, etc. And so empowering patients with knowledge could lead to them choosing a type of that best aligns with their values and wishes. And so so I was always a sort of an advocate for palliative care within the critical care setting. So to have a palliative care team come and see these patients, for example, was something that I did advocate for on behalf of my patient. So when MAID became legal, I was intrigued as to how this might look different to the deaths that I witnessed in the critical care settings. And so I volunteered to join the MAID team of the organization. At the time, it was in Ontario. And I joined the team, and I was involved in MAID provisions within the organization that I worked for as in the nurse capacity. So that's how I got involved with MAID. And so in that work, I did notice some gaps in how MAID was, how people were able to access MAID, and also some of the restrictions within the legislation, how that impacted certain people were topics of interest. So when I enrolled in my PhD program, that is an area I wanted to sort of spend time researching. And that's how, that line of work sort of unfolded.
Mm-hmm. Yeah, I can really hear your passion on this topic, and yeah, it's such an important area of work to give people a good death. Now, we know that MAID is becoming a very increasingly relevant topic of discussion in terms of ethics and bioethics and, in the public discourse and all of that. Could you describe what MAID means and how it works within the context of the current legislation here in Canada?
Yeah, so in Canada, the MAID process involves the administering by a medical practitioner or nurse practitioner a substance to a person at their request that causes their death, or prescribing or providing by a medical practitioner or nurse practitioner of a substance to a person at their request, so that they may self-administer the substance and in doing so result in their death. The former is the more common practice, where it is administered by the physician or the nurse practitioner, whereas in the States, the latter is the only practice that is legal. And so that is how MAID is administered. So who can access MAID in Canada? In order to be eligible for MAID, the person must be 18 years of age or older, must be eligible for publicly funded health services in Canada. So people cannot come to Canada and ask for MAID, for example. As a on a travel visa, for example, they have to have eligibility for healthcare in our country, and they have to have decision-making capacity to access MAID, and they also have to be able to provide informed consent to receive MAID, and this should be after they're provided information about other means available to relieve their suffering. And the patient should also make a volunteer request for MAID. Another stipulation in the legislation is that the person must have a grievous and irremediable medical condition, which means that they should have a serious and incurable illness, disease, or disability, and be in an advanced state of irreversible decline. And that they are enduring physical or psychological suffering that is intolerable to them and that cannot be relieved under conditions that they consider acceptable. And so in addition to these legislative requirements, there are also some safeguards. And in Canada right now, there are two different or a separate set of safeguards. One is for persons whose death is reasonably foreseeable. So they have a different set of safeguards to people whose deaths are not reasonably foreseeable. So for the reasonably foreseeable, that's the safeguards we use the track 1 safeguards, and then for persons whose death is not reasonably foreseeable, we use another set of safeguards, which we refer to as track 2 approach to MAID, or track 2 safeguards for MAID. So that's how the MAID process has been. That's how it is currently in Canada.
Thank you so much for sharing all that information. I think you really clarified a lot of the points that some of the public might be a little bit unsure of. Now, I'm wondering if you could describe the ethics of MAID provision in a nutshell, just the most salient points from your perspective.
So some of the ethical challenges is the difference in how MAID can be accessed by people who live across the country. So MAID is a little bit more accessible in some areas than it is in others due to the resources available in those areas. For instance, in rural settings, it would be hard for Canadians to access MAID versus, in South Island, for example, where there's lots more healthcare settings and clinicians who may be willing to provide MAID if you look at island health as a context. The other ethical challenge, or when MAID was initially established, something that I had experienced is patients asking for MAID early in the trajectory of their illness, or them withholding medications or other symptom management treatment options in order to maintain their capacity to consent for MAID. And so that was really a challenging to experience, because the whole idea of or purpose of MAID is to relieve suffering, but then if patients were withholding pain medications, that would result in them experiencing suffering while they awaited MAID. And so this sort of was somewhat reduced these practices with the introduction or changes to the legislation that came forth in 2021 with the introduction of a waiver of final consent. So an eligible patient who has the capacity could enter into an agreement with the healthcare provider to waive that final consent for MAID, which allows them to access MAID even if they lost capacity after being found eligible. I just want to clarify that advance request for MAID is still not legal in our country, so you do need, a person does require mental capacity in order to request MAID. Another access-related issue is currently being challenged in BC. And so these are non-participating healthcare organizations, and this could be because of their philosophy, the organizational philosophy, and or this could be because they are faith-based organizations. They do not allow MAID within their premises. And so what that means is that the patients have to be transferred out of these organizations into other areas where MAID can be provided. And this can be extremely challenging. Imagine this patient who's in a hospice setting, whose suffering is not relieved by the care that we're providing. Imagine having to transfer them, which would, increase the suffering that they're experiencing. And so can be very distressing for the team involved, for the patients, as well as the family. And so that is, ethically problematic. And of course, there has been the expansion of MAID to persons whose death is not reasonably foreseeable, and that does pose, ethical challenges in itself. That expansion was introduced during the pandemic, where the issues of access to healthcare was at its peak. That it was harder for our citizens to access basic healthcare, and so this came out at that time. So that law has been challenged by people in that how can MAID be legal or easier to access than other healthcare resources within our communities. And on saying that, it is also important to think about access to MAID for those individuals who have been receiving treatments but are suffering, and would like to access MAID. So it's just something to think about. It is a point of contention when it comes to death, people whose death is not reasonably foreseeable, or access to MAID for those individuals. So those are some of the ethical challenges that that are currently prevalent within the MAID legislation. Yeah.
Well, thank you so much for illustrating all of these pieces of the MAID ethics puzzle. I feel as though you've really informed our audience really well there. Now, I'm hoping that we can dive into your thoughts on the misconceptions around MAID that are pretty visible in current public discourse regarding this topic?
Mhm. There are quite a few. I think there is sometimes people do think that MAID can be requested, even if someone does not have the mental capacity to do so, that a proxy family member could ask for it. And there's misconceptions that they could put it in the advance directive and then people can access it that way. And that is not currently legal in our country. And so a person has to request for MAID on their own, and they need capacity to make that informed decision. And so that is one of them. And then there is also a belief that it may be easy to access MAID, and I sort of touched on some of the barriers to accessing MAID. And that would depend on where you are in the country or even within our health authority. And although there is a high prevalence of MAID, it's not, as soon as someone goes in and asks for MAID that they are then found eligible. There is a rigorous process involved there, and we need to find an assessor as well as a provider who both need to do independent assessments and establish that the person is eligible for MAID. So it's not something that that can happen as quickly as some people might imagine. That's often a misconception when I'm talking to patients or families. That is something that they think that it could be, and it's not an emergency service, if that would sort of explain that better. So it has to be planned and there are certain steps in place that needs to be completed. And this is especially so for persons requesting Track 2 MAID or for persons whose death is not reasonably foreseeable. So the safeguards are more, there are more safeguards, and that process is, longitudinal. It will take longer to establish their eligibility. So the other things are that sometimes people do think that MAID and palliative care, it's either MAID or palliative care that people can access, but in fact, in our community, we can access both at the same time, and the best outcomes are when supportive resources are available to patients while they are awaiting MAID. So that is another one. And then, of course, there has been a lot of discussion about MAID in the media and how it's been depicted in the media. And so some of those headlines that we read can be misleading. For example, some stories do talk about unhoused persons accessing MAID. However, it has to be clarified that they need to meet all the criteria as it's established in the law in order to be eligible for MAID. So it is not their unhoused status that makes them eligible for MAID. It is that they meet all of the rest of the criteria that would make them eligible for MAID. But of course, and one of those is that they are experiencing suffering, and that's related to their illness. But obviously, their social economic vulnerabilities could also add to a layer to that suffering. It is challenging to untangle that. But it's just something to keep in mind, that it is not particularly their status that's making them eligible. It is that they're meeting all the criteria as established in the law. Yeah, so those are some things that I can think of right now.
And I get the impression that regardless of the context for a particular individual, there are quite stringent regulations and, procedures that we go through in this context to ensure that MAID is appropriate for that person. Would you agree with that?
Absolutely. And it's not, something else I want to add to that is that a lot of healthcare providers may find MAID for persons whose death is foreseeable morally acceptable, or that's something that they would, participate in. Whereas MAID for persons whose death is not foreseeable, that is a completely different sort of, or at least for me, I find that a very different situation. And I do for myself, I believe that this, my, sort of support for it would be on a case-by-case basis and depending on individual situations. And I think for a lot of healthcare providers, it would be as well. It is this work is they're coming forward to partake in this work. It's not part of their role, and so for most practitioners, and so this is not a decision that they take lightly, and it does cause a lot of moral distress for some of them, especially the tractor, because it can be challenging and it can be a rigorous, tedious process that is time consuming and it takes up a lot of resources. And so it is not as easy as it may seem. Yeah, so that is just from my own experiences. So yeah, that's a great question.
I really appreciate you sharing your perspective with our listeners today. Now, you've already spoken a little bit about the grace and dignity that MAID can offer for some individuals. Do you have anything else you would like to share regarding the dying process and that capacity to promote dignity and grace for people that are going through a really challenging part of life?
Yeah. So I do want to preamble this answer by saying, MAID is only one of the options at the end of life. And so for me, I find a dignity in death is whatever one perceives that to be. So, and that could be very different for different individuals. And so, so to me, how we can, provide a dignified death is by empowering people with knowledge about and providing them with resources so they can know about their disease progression, for example, and that would help them know what options are available to them, and that then they are making a decision that is informed. And that is, for me, that is the way we can preserve dignity in helping someone identify what end of life would look like for them. And this could be, for some, it would be a choice of, aggressive treatments till the very end. Let's say if it's cancer, they want to try out those treatments till the very end. And should be respected if they are given every option, and that is what they choose. Or they could, choose to go with palliative care. And of course, that can be a dignified death as well. And or even a combination of all of them, right? And so some people request for MAID, and once they're found eligible, it gives them a sense of relief, and then it's a back pocket option that they have. They will only choose if they need it, but there's so much comfort for them in knowing that that is an option for them. And so that is sort of my take on what could be a good death and what could be a dignified death, is that empowerment of patients and giving them knowledge and giving them the access to resources that will allow them to have a death that they desire.
I really love the way that you framed that, the idea of really empowering the individual to have the type of death that fits for them. Now, I'm curious what you see as kind of the next steps, or what MAID legislation might look like in the future.
So as you may know, MAID for persons whose sole underlying reason for request is mental health disorders, and that was meant to become legalized in March, and now they've postponed it for the next. I think they're reviewing it, and they're looking at revisiting this in the next 3 years. So that is one. The other is there was a lot of support for advance requests for MAID to be legalized. It is still not legal, but that might be something that may become legal in the future. In some countries, MAID is legal for mature minors, and there has been some review of what that might look like here as well. But those things are not legal currently, but things that they are looking at for future. Yeah.
Well, thank you for giving us a bit of vision as to what's being looked at now and what might come later. Now, finally, I'm just curious in terms of how people can find out more information and learn more about MAID if they're, perhaps wondering about it for themselves, or are feeling apprehensive about it and just would like to be more educated.
Yeah, and so that's a great question. I think I think it's important to, even if this is something that someone is thinking about, it's good to start having those conversations within the family. Death is, often seen as a subject that nobody wants to bring up. It's the elephant in the room. We're all going to die, but it's very hard for us just because of how we are, sort of, our society has, been cultured into thinking about cures or finding cures or prolonging life, and not really thinking about what quality of life might mean, or what our end of life choices might be, etc. So I would say, a good way to start is to have having honest conversations with family members, but also importantly with GPs or primary care providers, talking about or really having an understanding of one's own health and one's own, illnesses, comorbidities, whatever those might be, having a good understanding of what that progression might look like, and having conversations about options with general practitioners. And MAID might be one of them, but it's not the only one, right? So what resources are available for supportive care, treatment options, etc. So that would be a great first step. But if there is curiosity about MAID, particularly the Ministry of Health BC website has lots of information about MAID. There's information about MAID forms, how to fill out forms. All of that is in the Ministry of Health website. So if you just type in MAID BC in Google, it should come up. Island Health's website also has information for the general public. There is a contact information there as well. So if you want more clear, information, that would be, and that's, for the local services that are available, that would be a good venue. And you can either email them or call them, and they'd be happy to assist as well. And then, of course, there are also volunteer organizations such as Dying with Dignity, Canadian Association of MAID Assessors and Providers website. There are other organizations as well. Here in Nanaimo, there is a voluntary organization called Butterfly House Society, and that organization is in its infancy, but the goal is to support patients through their MAID journey. So there's lots of things that can be found online.
So much for sharing all of those resources. That's fantastic. A great jumping off point for learning more. Absolutely. And I just want to thank you so much for your time today and sharing your knowledge and perspective on this very complex topic. We really appreciate your time and your willingness to expand the knowledge base of our community.
Yeah, of course. Thank you for having me.
You're listening to The Sound Constitution here on CHLY 101.7 FM, where we work to demystify health topics, and today's episode is on MAID. We'll be talking about death in this episode, so if that is a triggering topic, then this may not be the episode for you. But make sure to tune in next week. Now, let's get back to the episode. Thank you so much, Dr. Caroline Varieth and Lara, for that informative interview. As they both mentioned, there are many myths surrounding MAID. So we're going to take some time now, and Shan is going to explain some of those myths and give you the facts to help demystify them.
MAID is a topic that often sparks debate and misinformation, so it's crucial to separate fact from fiction. In this segment, we will be exploring some common myths about MAID, and we will shed light on the realities of this end-of-life option. So one of the common myths surrounding MAID is that people who request this end-of-life option usually do so because they are experiencing severe, intractable pain and suffering. And this statement is not true, as according to a study facilitated by the National Library of Medicine, most requests for medical assistance in dying are not made by patients experiencing untreatable pain or suffering. The main reasons for requesting MAID were self-perceived unacceptable quality of life, primarily due to loss of independence, mobility, ability to communicate, sense of purpose, and participation in meaningful activities. Some individuals also experience fear of future suffering and disability, and interestingly, pain was seldom mentioned as a cause of suffering in these cases. And the study's findings are supported by data from Health Canada's fourth annual report on MAID in 2022, which revealed that the most commonly cited sources of suffering by individuals requesting MAID were the loss of ability to engage in meaningful activities with 86.3%, followed by the loss of ability to perform activities of daily living with 81.9%, and the least cited concern was inadequate control of pain or fear of pain management with 59.2%. Another myth surrounding MAID is that mature minors will be eligible for medical assistance in dying in March 2024, and this statement is not true. According to Health Canada, MAID is not currently available to individuals under 18 and will not be unless amendments are applied to the Criminal Code. In many jurisdictions across Canada, mature minors already have the right to make important decisions regarding their health care, and this includes the right to consent to or refuse life-saving medical treatment. However, this is a separate issue and has no connection to the legalization of MAID for minors. Although in the final report of the Special Joint Committee in 2023, it was recommended that minors who are deemed to have the appropriate decision-making capacity should be eligible for MAID, with appropriate protections and safeguards, including that access to assisted death for minors should be restricted to those whose natural death is reasonably foreseeable. This recommendation stems from the committee's belief that eligibility for MAID should not be denied on the basis of age alone. But again, there is no currently legislation proposed in Canada that addresses the eligibility of mature minors for medical assistance in dying. Another myth surrounding MAID is that MAID is a common choice for individuals who are elderly or disabled, and this statement is not true. As a matter of fact, MAID is not solely requested by elderly or disabled individuals. The decision to seek MAID is based on individual circumstances and personal beliefs, and age or disability alone are not determining factors. According to Health Canada, the most underlying medical conditions of those who have received MAID in the year 2022 were cancer with 63%, cardiovascular conditions with 18.8%, other conditions with 14.9%, respiratory conditions with 13.2%, and neurological conditions with 12.6%, and these findings are consistent with cancer and cardiovascular diseases being the top two leading causes of death in Canada. And with regards to age, according to Health Canada, in the year 2022, the average age of individuals at the time MAID was provided to them was 77 years. This average age is slightly higher than the average from 2019 with 75.2 years, 2020 with 75.3 years, and 2021 with 76.3 years.
Dr. Stephanie Green, based in Victoria, BC, was a pioneer of assisted dying, even becoming a medical advisor of the BC's Ministry of Health MAID Oversight Committee, and was the founding president of the Canadian Association of MAID Assessors and Providers. And we're going to listen to her TED Talk about how her view of dying shifted with MAID.
What if you could decide at the end of your life exactly when and where your death would happen? Maybe, instead of dying alone in the middle of the night in a hospital bed, you could be at home at a time of your own choosing. You could decide who would be with you, holding your hand or even embracing you as you left this life. And what if a doctor could help ensure that your death was comfortable, peaceful, even dignified? You might never look at dying the same way again. 100 years ago, most people in North America died at home. Modern medicine has saved and extended countless lives, but it also took the majority of deaths out of our homes and into our hospitals, so we've become removed and unfamiliar with death and dying. Our current medical model likes to frame death as an enemy rather than a natural stage in life. So some of you may have memories of loved ones who are dying that are less than ideal, maybe in an acute care hospital, perhaps attached to machines that were monitoring irreversible decline or receiving treatments that could no longer stop their illness. Some might even have been begging for your help to end their suffering. Palliative care is an approach that optimizes quality of life over quantity of life. But every clinician knows there are times when no approach will adequately relieve a person's suffering. So what am I talking about? I'm talking about assisted dying, the legalized, compassionate end-of-life care provided by clinicians who safely and effectively end a person's life in specifically safeguarded circumstances, which include the explicit request of a competent adult. Assisted dying. Now, right about now, there's a few thousand people, myself included, who are fairly flabbergasted that I'm standing here and talking to you about this topic today. Not the least of which is because for 22 years, I was a maternity doctor delivering life into this world. Then, in 2015, the Supreme Court of Canada struck down the prohibition of assisted dying, and our government legislated this new field of healthcare. And I became one of the first physicians in the country to offer assisted dying to people who met all of the required criteria. How has this played out in my life? Well, my husband likes to joke he now sleeps with one eye open. But seriously, I have met the most extraordinary people. I knew from the first moment I met him that Ed was an eccentric man, 68 years old, and he was proud to say he had never held a job and had lived the life of a free spirit. Like over 65% of the people I work with, Ed had a cancer that had progressed to the point that he would be dying soon. It was impossible for him to even venture outside, and life confined within four walls was simply not a life for Ed. When I arrived on the day of his scheduled death, we chatted for a while first, and after a few minutes, he excused himself to go to the restroom. I was shocked when 2 minutes later, he returned wearing a full clown suit. Tie-dye pants, a t-shirt, a colorful clown wig, and a red nose. Despite all our previous interactions, I'd never realized Ed was an amateur clown. I asked him why he'd chosen to wear the clown suit on that day, and he told me he wanted to go out laughing. Are you sure you're ready? Oh yes, I am certainly ready. He was lying there, all colorfully laid out and staring straight up at the ceiling. Not nervous, not sad, but not smiling. I was standing to his left, close to the bed, with my medications laid out beside me on the bedside table. And often at this time, as I begin giving the medicine, I'll guide my patients to a cherished memory. But on that day, I leaned over instead and asked, Ed, why don't cannibals ever eat clowns? Well, he turned his face towards mine with a really big smile, and he answered, because they always taste a little funny. And we were nose to nose, and both of us grinning from ear to ear. And I heard him chuckle as he turned his head back to a comfortable position. And then he closed his eyes and fell asleep. And some moments really stick with you. Ed's story really encompasses so much of what I want people to understand about assisted dying, that it's an individual's choice, that what's most meaningful to the person is what becomes most important, that levity and humor can be acceptable, and that an assisted death in ways big or small almost always reflects a person's life and how they chose to live it. You might be surprised to discover assisted dying isn't new. When I began this work in 2016, there were already 6 countries outside of Canada where some form of assisted dying was permitted, and 5 states within the US. Today, there are 14 countries where assisted dying is legal, and 11 regions within the US alone. Why do you think there's been so much recent change? I want to tell you about Harvey. By the time I met him, Harvey was 74 years old and dying of end-stage liver failure. I met with Harvey and his wife at his home on several occasions. There is, of course, a rigorous process to be followed, a number of eligibility criteria to be met, and procedural safeguards to be satisfied. You can't just call up and ask for an assisted death. Harvey was terminally ill, but still very capable of speaking for himself. And within a matter of days, I was able to confirm that he was eligible for an assisted death. And then something remarkable happened. Harvey immediately stopped worrying about how he would die and spent the rest of his days focused on how he wanted to live. Harvey planned and attended a weekend open house in his home for neighbors and friends to come say goodbye. He snuck a final sip of beer, and eventually we choreographed his death together. He told me who he wanted to be there and where he wanted to be, in his own bed, in his own home, and I quickly came to understand that Harvey wanted to die just as he had lived, self-made and in control. When I arrived at Harvey's home on the day of his death, we first spoke privately so I could confirm he hadn't changed his mind and to get his final consent. And then I prepared his family for what they could expect. When we finally gathered together in his bedroom, there was only Harvey on his bed, his 2 grown children close by, both of them holding him or touching him in some way, and his wife sitting on a chair to his right, pulled up close and leaning in. I was holding his left arm, ready to administer the medications, and Harvey was planning to die exactly as he had planned, being held by his family and gazing into the eyes of his wife. His wife of 52 years. Can you imagine? They connected there, forehead to forehead, whispering to each other as I began giving the medicine. She held his face in her hands and stroked his head and told him it was okay, that she loved him, that she would miss him, but that she'd be all right. She whispered inaudible words, and I saw him smile. And the intimacy of that moment was so absorbing. I'll admit I struggled to focus on what I was doing. She told him to let go and that she was there for him. And as was true on most nights of his life, hers were the last words he heard as he fell asleep. Another one of those images etched in my mind forever. Like I said, some things really stick with you. It's not always easy to explain my work. Can you imagine me at a cocktail party? Someone inevitably asks, "So what do you do?" I think the honest answer is, I help people. Death and dying are an inevitable part of life, but we've been removed from much of the process. Most of us are poorly informed about what we might expect and often fearful of even asking to talk about it. But I urge you to take a closer look, because assisted dying is humane, compassionate care. It will certainly change the way we consider our options at the end of life. But take a closer look and you'll discover something more. That assisted dying is less about death than it is about how we wish to live. Thank you.
You're listening to The Sound Constitution here on CHLY 101.7 FM, where we work to demystify health topics, and today's episode is on MAID. We will be talking about death in this episode, so if that is a triggering topic, then this may not be the episode for you. But make sure to tune in next week. Now, let's get back to the episode. We just heard from Dr. Stephanie Green and how MAID was able to give her a new perspective of death and provide a dignifying death on your own terms. In her speech, she mentioned the concept of a good death. So Cedric is going to go into a little more detail about what that means in our next segment.
What is a good death? The concept of a good death arose in the hospice and palliative care movement and has been described as a multifaceted and individualized experience. The Institute of Medicine defines a good death as, and I quote, one that is free from avoidable distress and suffering for patients, family, and caregivers, in general accord with the patient's and family's wishes, and reasonably consistent with clinical, cultural, and ethical standards. Providing patients with a good death is becoming increasingly important due to the lengthening lifespan of individuals and the increased use of supportive and other medical interventions, which leads to longer end-of-life periods. A good death encompasses many aspects, such as the delivery of early palliative care and supportive end-of-life care. Supportive care means having palliative care delivered by a healthcare provider in a person's home instead of the hospital. Palliative care means care that is focused on quality of life and the management of symptoms. The idea of a good death takes into consideration the control of symptoms, ensuring comfort and having the hard conversations where the risks and benefits of treatment are weighed, instead of purely focusing on only medical interventions. In an article, Dr. Katie Goldie, an assistant professor in the School of Nursing at Queen's University, describes her grandmother's death in the hospital where seeking a cure was the sole focus. This meant lots of time in the hospital, tests, and side effects from treatments. No one talked with her grandmother about her end-of-life wishes. Situations like her grandmother's are why it is so important to discuss with a patient what their wishes are so that healthcare providers can provide them with a good death based on their wishes.
The concept of a good death is what makes MAID so important. It gives the patients a choice to die in the way that they want, with who they want, and how they want it. It gives back the dignity and control people often find is missing when dealing with serious illness. Whether someone chooses MAID or a different treatment is up to them and what they wish and think is best for them. We're just here to spread information so everyone has a better understanding about one of the options that are out there for end-of-life treatment. Thank you everyone for listening this week. I want to give a big thank you to our guest for this episode, Dr. Caroline Varieth, for taking the time to do this interview. As well, thank you to my co-hosts Shan, Lara, and Cedric for all the work you did on this episode about MAID. For details and show notes from today's episode, or to follow along on what's coming next this season, check out our Facebook page, A Sound Constitution, or our Instagram, CHLY A Sound Constitution, all one word. We want to remind our listeners that the information presented on this show is for educational purposes only and does not replace the advice of your primary healthcare professional. Thanks again, and we hope you all have a wonderful rest of your day.